So welcome everybody to our lecture, which is about the scale-up and sustainability of participatory learning and action to address type 2 diabetes in rural Bangladesh. I'm Dr. Joanna Morrison, and I work at the Institute for Global Health in the UK.
I'm Dr. Abdul Kuddus. I work as Deputy Director at the Center for Health Research and Implementation under Diabetic Association of Bangladesh.
Today, we're going to be talking to you about a case study of our research and how we research the scale-up and sustainability of it.
A DMAGIC trial uses community mobilization through participatory learning and action cycle, commonly called PLA cycle. PLA is a four-phased cycle of problem identification and prioritization, strategy development, implementation, and evaluation. Practically in the community, group members sit together, and group members, with the aid of locally recruited facilitators, identify the problems and prioritize the problems using the common local resources and as their capabilities they have in their hand without seeking much more external sorts of services. After prioritization of this problem, they then share with their findings with the wider community through community meeting, and they get feedback. And after sharing and getting feedback, they sit together again, and then they implement the studies in the communities and assess the impact of the implementation. The most commonly used strategies were taken by the group are awareness raising, group exercise, vegetable gardening, and sometimes locally organized diabetes screening. DMAGIC trial showed a large reduction in the combined prevalence of type 2 diabetes and intermediate hyperglycemia in the PLA groups with compared to control group with an absolute reduction of 20.7%. And during the baseline study, we assessed the blood glucose level who have high blood glucose level than normal but have not reached up to the diabetic level. We call it intermediate hyperglycemia. And we assessed more than 2,000 people with intermediate hyperglycemia. And we followed them up to 2 years. After 2 years, we again assessed their blood glucose level, and it was found that the 2-year cumulative incidence of diabetes was significantly lower in the PLA group compared with control group, with absolute reduction of more than 8%.
So we were obviously really pleased with those results, but we wanted to see if they could be sustained over time. And so we did research to find out whether PLA was effective in improving health outcomes after the project had finished. We also wanted to explore how to scale up the intervention outside of a research context. So we did these pieces of research using quantitative and qualitative methods, and then we piloted an NCD mobilizer intervention. So we went back to the 96 villages where we had ran the participatory learning and action intervention in 2001, and we found that no groups were still active. Half of those groups had not met since the trial ended. We also found that the effects on blood glucose were no longer observed. But in previous intervention areas, we found that knowledge and awareness was increased, as well as increased levels of physical activity and hypertension management in the areas that had received the participatory learning and action intervention. So there were some sustained effects of this intervention. We did some qualitative research to find out why the groups hadn't continued meeting. And there were three main reasons for this. The first reason was that group members and communities felt that the effect of the group had been sustained. So people had changed their behavior and were continuing to behave in ways that would reduce their diabetes risk. The second reason was that communities felt they needed someone trusted, trained, and resourced who could give them information, such as the facilitator who had ran the groups in our study. They felt like they wanted someone to give them new information who was from outside of the community, from an organization that was trusted, such as ours, to provide that information. Gathering people and running a group is a lot of work. And that work really should be remunerated. We also found that it's not socially acceptable to be doing that kind of work and that amount of work for free. So we did some research to find out how groups could be sustained, whether that would be within the health system or through other means. So first of all, we mapped the stakeholders and did some key informant consultation. Then we did interviews with key stakeholders and analyzed that data iteratively. And we took that analysis and explored some of the ideas with stakeholders at the community level. So group members, as well as government health workers and politicians. Then we analyzed and made some recommendations from that work. So we found that the scale up of participatory learning and action was considered feasible and acceptable. Community groups in Bangladesh are very common, and this was seen to be, a very, very feasible way of intervening with the community for diabetes. There was also a preference for scale up through existing health systems, but we did find that there would be challenges if that was the case. The first challenge was that there would be limited flexibility to let the community lead. So community groups would have to work within the norms and rules of the government health system, which would prevent them from taking any action that they wanted. For example, if they wanted to work with the private sector to do screening. We also found that most community health workers, government community health workers, are based in institutions, and so it's very difficult for them to move to the community, to mobilize the community and run groups. Most community health workers are also women, and services have historically been focused on maternal and reproductive health. And so those female health workers might have difficulties engaging with men. The gender norms in Bangladesh might also prevent those female community health workers from engaging with men at the times when men are free, for example, in the evenings or at their workplace, when it's not really acceptable for women to be out late at night alone in the community. So Dr. Kuddus is going to tell you about the NCD mobilizer intervention, which we piloted on the basis of that research.
As part of the scaling up of PLA intervention, we have included health screening services with the PLA activities for early detection, counseling, and appropriate referral for common non-communicable diseases such as measuring blood glucose, blood pressure, and obesity in the areas where PLA activities have not performed before. We have recruited the facilitators who have previous experience in delivering the PL activities but does not have any health screening activities. The NCD mobilizers were trained by the qualified physician from the Upazila Health Complex, and they are also provided training on screening protocol as well as referral mechanism. The whole idea behind adding this health screening services with the PL activities is to generate revenue from the community and to cater the growing needs of the community for health screening and referral services. And we strongly believe that if we could generate money from the health screening services, This would ensure community participation as well as subsidizing cost of the health NCD mobilizers. Process evaluation used mixed methods and focused on the feasibility and acceptability of the intervention. Feeds into the refinement of the intervention as CS Center for Health Research and Implementation are continuing this work after completion of our research. The quantitative results are from 2 months, November and December 2023. It was observed that more women than men have been screened. This is because harmful gender norms limit women's movement and access to resources to go to pharmacies for screening, and our mobilizers provide care usually at the place where the group meeting is held, but not at the same time. You can have any combination of screening, that is, all three or whichever test you would like to get. Most people screen for diabetes because their meetings are about diabetes and they have less access to screening at pharmacies compared to hypertension, where screening is often free of cost. Many said that they have their own weighing skills at home to weigh vegetables and jute, so there was no need to screen for obesity. It was observed that only 4 people have been screened for free. This is because mobilizers are not offering free screening services for fear of being overwhelmed with requests and therefore being unable to follow this protocol.
So you can see from our research that running a participatory learning and action intervention within the current health systems context would be challenging, but there is potential for the PLE intervention to be sustained if it's paired with supported service provision or some way of sustaining itself. More research is needed about the long-term effects of participatory learning and action on health and on communities, and testing of the NCD mobilizer model or other similar interventions at scale. We hope you have enjoyed our lecture, and these are 3 associated references which you can refer to.